Dr. Elenita Usher. I'm from Belize, which is a country in Central America. That's where I grew up. I went to college there and then went to Guatemala, and I studied medicine in Guatemala City. After finishing medicine there, I went back to Belize and worked as a general practitioner for a few years before deciding that I needed to further my career, and I came to the United States. I had to do the United States medical exam, the USMLE, to get licensed here in the United States. So I spent a few years doing my USMLEs so that I can get certified to be able to practice medicine in the US. After that, I went into the residency program at Texas Tech University Health Science Center in Odessa, the Permian Basin. I did family medicine there. And after family medicine, or during the rotation, is when I became inspired to do geriatrics. I had a great mentor who was a geriatrician, and he showed me everything that was possible in geriatrics, and I got motivated. He encouraged me to do the fellowship program there, and I did the one-year fellowship program, and that's how I did the specialty in geriatrics. Looking back, I think I was interested in medicine since I was a child. I remember playing my dolls and being the doctor all the time, checking the temperature, giving injections, saying they're sick, and I was treating them. I didn't have any influence at the time, so I don't know where it came from. I guess it was just natural, or maybe I did a doctor's visit. I don't remember, but that was as far as I can remember. And when I finished college, I knew that's what I really wanted, so I did everything in the sciences while I was in high school and college. And then my parents didn't believe that girls should study medicine, so they kind of discouraged me, but I was set, and I decided I'm going to go that pathway, and I never wavered. I am in the same pathway, and I'm enjoying it the fullest. So through residency, I had a mentor, Dr. Chow Lei. He was a geriatrician at our program. He was passionate about geriatrics. I never thought I would do geriatrics. Actually, I didn't know much about geriatrics until I went into that program. And I would see the way he talked to patients, his bedside manner, his insight into what aging is, and the changes that you can make in patient care when you look at the patient holistically. The social aspect, the physical, the mental, and then combining that and getting a good thorough history, which in medicine we should do, get a good thorough history, and then coming up with a plan of care. And I could see the change and improvement in health when you look at that patient individualized and then come to an assessment and then go with the patient care that's specific for that patient. You see changes and improvement is in the quality of everyday life that you see. So that patient can go from being bedridden to becoming independent, or at least meeting what that patient goal is, because everyone has their own goal. The older we get, so when we're young, it's like we have all these guidelines that medicine gives us. You treat diabetes this way, you treat hypertension this way, you treat congestive heart failure with these guidelines. When you become in the older age group, the older you become, it becomes more individualized. Yes, we try to follow some guidelines, but now how will that affect you individually as a patient? So that's where we stand back and say, okay, giving you this medicine, what is the side effect? How will that impact your everyday life? Will it cause dizziness? Will it cause sleepiness? And then that's where we say that is the individualized medicine that we're seeking in geriatrics. And that is what made a big impact in making the decision that this is where I really wanted geriatrics. I find my profession very rewarding. I enjoy talking to my patients. I enjoy knowing who the patient is. So, where are you from? What have you done? Why are you in here? Like, what is your goal right now from where you were before? And just learning the family. Like, okay, what's your family like? Because then I can get a better perspective of who you are and where your goals might be. And then I think I can serve you better that way. So it's rewarding for me having a patient in my clinic and getting to know the social aspect. Apart from the physical, I think in geriatrics you have the ability to sit and make conversation. Spend a little extra time to know who that patient is so that then you can make a better plan of care for that patient. My perception of the duty that the physician has to their patient is to be a coach or a teacher and a guide to improve the health of the patient. So we're not there to say, do this, 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 and not explain the reason why. You come to me with a problem, you give me your confidence, you share very personal and intimate information. So we guide that with a lot of respect. And if you put that trust and faith in me, then I think that my duty to you is to do the best that I can to answer the questions that you have with regards to your health, be it physical, mental, social. Try to assist you in finding the best possible answer, because that's what the patient wants, an answer. How will I get better? How will treating my diabetes make me have a better life? So I'm there as a coach and as a guide. I have the knowledge and I can give you that knowledge, but you have to be very proactive also so that we partner together. It's a partnering relationship that we have. It's not one-sided, me telling you what to do, but it's me assisting you and educating you in what you should be doing to help improve your health, your life, the quality of life especially, because that's what matters in the end. What is your quality of life? Because you could live years bedridden in a wheelchair, or you can live years in good quality, being independent, being healthy, having lifestyle where you're eating healthy and exercising every day, and you're happy with where you are at that moment in your life.